Yes,
Italian.
like in Italy.
Yes.
I hope that at the end of this year we stop.
Well, who knows? We don't know.
Yeah.
We don't know for sure.
We are live in YouTube.
Now in Italy is okay. The situation is okay.
Is the vaccine come in Italy?
Yes, yes, it's okay.
No, vaccine is not there available anywhere. Vaccine probably will come in some time. So I think we are live on YouTube. Dr. Lelli, we'll just start our program. I'll request our moderators and panelists to mute their videos so that we can go live. And I welcome everyone for this knee arthroscopy academy knee ligament injury webinar. And we have Dr. Alessandro Lelli as a speaker, as a faculty today for our webinar. And he's going to speak on different topics of knee ligament injury. Dr. Lelli doesn't need any introduction in India. He's a very popular figure. He has visited India many times. He has performed many live surgery. And we all have experienced his surgical skill. And we have seen his surgical skill as well as his technical tips, which are very, very important in PCL and ACL reconstruction. So without any delay, I think we will proceed with the lecture. For today's program, we have the moderators in the form of Dr. Atik Vasdev, Dr. Rajkumar Amravati. So Atik and Rajkumar, can you start the today's program?
Okay, Dr. Rajkumar.
Yeah, Atik, to start there.
Hi friends, good evening on this Sunday evening. Welcome to be back. Nice to be back with all of you. Let me invite Dr. Lelli. Everyone knows him. He's famous for his surgeries in India and of course the Lelli test. So Dr. Alexandro, could you please start your presentation?
Yes.
Over to you, sir.
Yes, the first presentation is about ACL clinical examination. First of all, I want to thank the faculty and Roshan to invite me in this live webinar. This is where I work. I work in hospital Villers in Italy.
Dr. Lelli, you have to start your, you have to share your desktop. You need to share your screen. Share your screen, yeah.
Okay.
Yeah.
Okay.
Yes. So start from first slide. Okay.
Okay.
Yeah.
Okay. This is where I work. I work in Bologna. Bologna is a little city in the center of Italy. This is my clinical experience, about 34 years of surgery experience, 1,200 cases by years, 50% about sport practice, and 50% about arthroplasty practice. This is ACL. ACL is in the center of the knee. We have two bundles, posterolateral bundle and anteromedial bundle, that are not isometric. And a good history and physical examination is a key to a correct diagnosis. In Italy now we have internet, also in the world, newspaper, TV, and the patient wanted to know everything about the knee. And he wanted to know everything also immediately after the accident, not the day after, immediately. So we need to understand very well the initial pathology. We asked to the patient extended history. We needed to do a physiological examination and a clinical examination. And we can help about standard radiography and spatial imaging. The result of clinical tests require specific biomechanic principle for a correct diagnosis of ligament defect. We see the two bundles of ACL. One bundle is tight in extension and the other bundle is tight in flexion. So it's not isometric. And very important is to do a difference between laxity and instability. Instability is laxity. Laxity is not instability. And we need to remember that the ACL is in the center of the knee, is not in the periphery. So in my experience, in 92% of the patient, if you have a lesion of ACL, sure, we have a lesion also of other structure. For example, of the medial collateral ligament, we know we have one superficial bundle and one is a part near the knee. We have a POL is very important. PCL, posterolateral, lateral with the lateral collateral ligament, and anterolateral ligament. That for me is not a problem of anterolateral ligament, but a problem of a fascia lata. And very important is the meniscus, lateral meniscus and medial meniscus. The root of meniscus is very, very important. When we have an accident in the field, the patient has pain, the patient is afraid, and immediately he wanted to know what happened. But not only the patient, also the president, the trainer, the manager, the public wanted to know immediately what happened. So what I suggest is never hesitate to take the injury athlete into a more conducive environment, like a training room or a locker room, to explain what the options are. You can see in the left side, the Milan training room, and in the right side is my consulting room. Very important is to hear also, because the president of the team wanted to know immediately what happened. The patient is afraid, have pain, and sometimes is also like in this situation, because he is afraid for the career. Remember, very important is the physiological recovery. Up to 2,400% of the athletes who do not return report fear of reinsurance as a primary reason. So we needed to explain very well to the patient what happened and the future. This is what I suggest. So the first is the pain. Where is the pain? Pain can be in the lateral side, 1, 2, 3, 4, 6, 7 position. In the medial side, also in this position, we have 7 position, different position, or in anterior position, knee side, where we have 10 position of the pain. And which position, it means one lesion. The first step is MRI. The diagnostic value of clinical test, magnetic MRI, and instrumented laxity is the differentiation of complete versus partial anterior cruciate ligament. You can see in the left side a total lesion, and in the right side we can see a partial lesion. The anterolateral bundle is intact, but the posterolateral bundle is broken. What I suggest is, if you have the possibility to do not only a static MRI, but also a dynamic MRI, because remember that ACL, like PCL, are not isometric. You see in this slide, an MRI, normal MRI, you can see the lateral compartment, for example. It seems to be normal, no lesion. But if you do a dynamic MRI, you can see a lesion of the lateral side. This is an MRI in clinostatism when you can see a normal ACL, clinostatism, normal ACL, but the same patient in orthostatism, you can see a lesion of ACL. So if you have not a dynamic MRI, but very important is to do always a clinostatism MRI and orthostatism MRI. The majority of orthopedic are very skilled in the diagnosis of ACL chronic lesion, but the problem is in partial lesion and in acute lesion. We have a lot of paper. You can see 1, 2, 3 paper about the evaluation of the clinical test of ACL lesion and the accuracy of the 3 diagnostic tests for the lesion of ACL. So what I suggest to do always dynamic test, functional test, and active test. This is the active test. They are designed to reproduce the subluxation process, but are frequently negative in acute lesion. I think 100% are negative, and frequently negative in partial lesion. So for me, it's very easy to do this test only in chronic lesion. Passive test, anterior drawer test. But remember that this test is frequently negative with meniscal lesion. It's difficult to do in obese patient. It depends about the tibia rotation, the patient, if the patient has pain, if the patient is afraid, the age of the patient, and frequently negative in acute lesion. Remember that anterior drawer test is generally normal in patients with intact secondary restraint like iliotibial band, medial capsules, lateral capsules, medial collateral ligament, and lateral collateral ligament. So anterior drawer test is positive for me in chronic lesion, and if you have a lesion also of the anterolateral ligament, for example, of fascia lata, of the medial compartment, of the lateral collateral ligament. And also it depends the foot of the patient, because if the patient has the foot in 90 degree, in straight position, was okay. But in extra rotation and intra-rotation, it depends about the medial collateral ligament and the lateral collateral ligament fascia lata. Lachman test, very easy to do, but sometimes is negative in acute lesion, frequently negative in partial lesion, and difficult to do with small ends. So you can do the Lachman test also with the KT1000 and KT2000, but remember that also this test is frequently negative with meniscal lesion, buccal handle lesion, frequently negative in partial lesion, the patient, because the patient has pain, and applied force is difficult to control. So, jerk test, very easy to do, but to do this test in acute lesion is impossible. To do this test with small hands is impossible. If the patient have a tight iliotibial band, is impossible, and difficult with advanced arthritis. And remember, if the patient have a mild tracking of patella, subluxation of patella, this test is positive. You can see in this video, the jerk test may increase by concomitant injury of the medial compartment. If you have a lesion of the medial compartment, jerk test is explosive. And also the role of the lateral meniscus. After a lateral meniscectomy in ACL deficient knee, the anterior translation of the lateral compartment increased during the pivot shift test by 6 millimeters. And also the role of the anterolateral ligament. That for me is not a problem of anterolateral ligament, it's a problem of fascia lata. If the patient have a negative jerk test and you cut the fascia lata, the patient have an explosive jerk test. In fact, in assessing anterior tibial translation and the rotatory laxity after transecting the fascia lata in ACL deficient knee, we have found increased rotatory laxity at 30, 45, and 60 degrees of knee flexion. And we have an explosive pivot test. Also, the morphology of the tibial plateau is very important. An increased tibia slope has been shown to correlate with an increase of this test. And very important, the size of the medial lateral diameter of the lateral tibial plateau is significantly smaller in patients with a high pivot test. Very important is the morphology of tibial plateau. Medial plateau is different from the lateral plateau. And to do this test with these two people, right and the left, I think that is impossible. If you have a small hand and an acute lesion, to do this test in this patient is impossible. This is a very, very famous player of NBA in the United States. He's an Italian player. You see the left knee. 2 days after this lesion, the patient arrived in Italy, to my consulting room with a brace. He had pain. He is afraid, and you can see that it's very impossible to visit. You see the hand of the patient. You see the big hematoma in the posterior part. It's impossible to move the knee. The patient have a very, very pain. Or this is another very famous basketball player. The trainer and the president do immediately, after 1 hour, an MRI, and ACL is intact. You can see the hematoma, big hematoma. You can see the contracture of the hamstring because the patient has pain. Anterior drawer test is totally negative, but not negative because the patient has pain. So some years ago, I studied a new test, and now in the literature in PubMed, we have a lot of paper about this test that I presented the first time to the academy. I presented this test to Clinical Orthopedic Society in 2014, to the Annual World Congress 2015, and this year to the meeting. If the belt is not tight, the paint fall down. I explain my test. You can see the foot come up, no problem. But remember that the only structure that begin from the tibial plateau is ACL. The medial collateral ligament, the lateral collateral ligament, the PCL, patellar tendon are not, the origin is not in the tibial plateau. On the contrary, ACL is the only structure that begin from the tibial plateau. So if the ACL is broken or doesn't work well, partial lesion, but the important is not, is good or not good. if the ACL works well or doesn't work well, you can see the foot don't come up. You can see the difference. This is a basketball player. You can see hematoma. It's impossible to flex the knee. So it's impossible to do Lachman jerk test. But if you do my test, the right foot come up and the left foot don't come up. You can do also my test with during dynamic MRI. This is a normal test, ACL is good. And here we have a lesion. So you can see the translation between tibia plateau and the femoral condyle. You can see very well the difference. This is the other basketball player. You see before, the MRI is negative, but the foot don't come up. So this is what I have seen in PubMed, different papers. You can see this is the accuracy of Lelli test to diagnose the ligament, and the conclusion that Lelli test was found to be a reliable clinical test for ACL tear, with sensitivity and specificity superior to conventional clinic method. This is another work of Nepal, and the conclusion is the same, that this test works well in acute and chronic lesion. Another paper, this is American works. We can see that our study result that for me is not 100%, but is 95%, is very important, like sensitivity and specificity. Other work, the same result. This is the last work about Indian colleagues, and they say the lever test has fairly good sensitivity as a Lachman test, and should be included in routine clinical examination. So for me, it's not only Lelli test. If you have a lesion, or you have a lesion of ACL, you are able to do Lachman test, jerk test, anterior drawer test, and I think that also the lever test is very, very important. Only one thing, because remember that in my experience, in 50% of the patient, we have a lesion also with a lateral, with a medial collateral ligament. In fact, is the medial collateral is the most common injury ligament of the knee. Distal, proximal, in the middle. You see this video. If you have a lesion of ACL and the superficial medial collateral ligament, we have a little laxity in varus. But if you have a lesion of posterior medial corner, it's more important. And if you have total lesion of the medial compartment, the pivot shift is explosive. Also, if you have a lesion of the POL, you can see with a dynamic MRI and with a scope. But very important is also the posterior lateral corner. Remember that the ACL is in the middle of the knee. So sometimes the medial compartment is broken, sometimes also the lateral compartment. We have not an isolated lesion of ACL. So very important when we are with the patient, courteousness, communication, honesty, gentleness, and compassion. At the end, what I wanted to suggest, in chronic lesion, okay, no problem, because the patient perhaps know what happened, You have already done 1, 2, 3 MRI, but the problem is acute lesion or impartial lesion. Thank you very much.
Thank you, Dr. Alessandro. Now I think we can have time for discussion on clinical examination of the knee. Anybody wants to ask questions to Dr. Lelli about his test, the liver sign or Lelli test, or any other part of clinical examination?
Can I ask one question?
Yeah, please, Dr. Anta.
Dr. Alexandro, what is the scientific basis of Lelli's test?
I think, if I understand well the question, the scientific is that ACL begin from tibial plateau. On the contrary, from tibial plateau. On the contrary, the other structure, like medial compartment, medial collateral ligament, begin 2 fingers below the tibial plateau, and the lateral compartment is also begin from fibula and from 2 fingers of the below the tibial plateau. Also PCL, if you know very well the insertion of PCL. If you need to reconstruct the PCL, the tibial tunnel is about 2 centimeters below the tibial plateau. So the only structure that begin from the tibial plateau is the ACL. So if you do the lever test and the foot come up, it means the ACL works well. So it's not a problem of intact or broken. If ACL works well or doesn't work well. So if you do an MRI and you have a total lesion of ACL, it's very easy, the diagnosis. But the problem is with a partial lesion or with a intrasynovial lesion. So what I wanted to show to the patient, the difference between one foot and the other foot. So very important is a partial lesion or in intrasynovial lesion.
Oh, this is the 5%, which is, it is not positive, is it?
In my experience, what I said also before, that my test, I can see that is a high sensitivity and specificity in 92, 93% of the patient, not in 100%. This is not right, but 92, 93 patient. Like anterior drawer test. For me, the 2 tests are anterior drawer test with the foot straight, not in extra rotation, intra-rotation, not the Lachman test, not the pivot shift, but anterior drawer test and lever test.
Is it also positive in a locked knee?
Yes. If you have a backer handle lesion, the patient have pain and the knee is blocked. But if you do my test, the foot come up, not in full extension, but 1-2 centimeters is foot come up.
Thank you.
Also, if you do an arthroplasty, for example, it's different. An arthroplasty, you can see, and you do my test, you can try. The foot don't come up because the first step is to cut the ACL. If you do, on the contrary, a unicompartmental arthroplasty where the ACL needed to be intact, my test is negative.
Yeah, Dr. Lelli, can you elaborate regarding your clinostat and orthostat MRI that you mentioned in your talk?
What?
Clinostat and orthostat MRI. Your MRI positions which you spoke, the clinostat and orthostat.
Yes. What, you wanted to show the slide? Because
Could you explain more about your positioning during
Yes.
MRI? Because
yes, okay.
you said about clinostat and orthostat position,
Yes,
but that is
because-
not the usual thing which is available in India. India we use the knee coils which are
Yes,
commercially
because
available?
in 80% of the patient, the lesion of ACL or the partial lesion of ACL is in the femur, not in the tibia. So if you do, for example, an MRI in acute patient, where the patient have a lesion, proximal lesion in the femur, not in the tibia, perhaps the ACL, it seems to be intact, but in orthostatism, the ACL go down, go in the tibial plateau, and you can see the difference. So if you have no dynamic MRI, because I think that dynamic MRI now is only in Bologna, it's not in the world. But to do an MRI in ortho and clinostatism, you can see not only the ACL, but you can see also a lesion of the POL of the lateral compartment. It's not difficult to do an MRI in ortho and clinostatism. It's very easy. Perhaps the patient has pain, but it's possible.
Okay. Any other question? For
Any
Dr.
other?
Lelli?
Dr. Rajkumar wanted to ask. Dr. Rajkumar?
Dr. Lelli. Hello.
Yes.
Yeah.
Sir, I understand there are limitations to do your test. Could you kindly tell us in which percentage of the patients you will find that this test will be negative, and what are those situations where it will be negative? Prerequisites and why the tests are negative.
What if I see a patient? The first step is a clinical examination, and always an MRI, because MRI is very important also for the lesion of the periphery and also the meniscus. If the MRI is negative and my test is negative, okay. If MRI is negative and my test or Lachman test, anterior test is positive, what I suggested to the patient is to do a diagnostic arthroscopy, always. If my test is negative, but also in the contrary, if my test is negative, but MRI is positive, always an arthroscopy. So I think that nothing is 100% of specificity and sensitivity. No MRI and no clinical examination. So for me, it's together. Orthopedic and radiologist need to work always together. In fact, in my consulting room is a door near my consulting room. We have an MRI.
Dr. Lelli, I have not still understood the scientific mechanism of extension of the knee when the ACL is torn. Normally, if there is a connection between femur and tibia, then when it is broken, it should not come up. So what causes the leg to come up when you hit on the thigh?
Because if you do, for example, a cadaver lab and you cut patellar tendon, the foot come up. If you cut the anterior lateral ligament or fascia lata, the foot come up. Also the medial collateral, also the PCL. Only if you cut or partial cut the ACL, the foot don't come up. So for me, the probe, the biomechanic is that the ACL begin exactly in the tibial plateau. And remember that ACL have two or three bundles, anteromedial, posterolateral. So in a lot of patients, if we have a partial lesion of ACL, sometimes Lachman or jerk test is negative, but perhaps it's positive in chronic lesion, not in acute lesion. And with the lever test, on the contrary, the foot don't come up. So for me, and also for my friend Freddy Foods that you know very well, the biomechanic of this test is the only reason that ACL begin from tibia plateau.
So that means, suppose say, if the ACL is not
is torn,
huh?
doesn't work well, is different. The other tests are dynamic test or function. My test is a functional test. It's different between dynamic test and functional test. With the lever test, I wanted to show that in this patient, ACL doesn't work well. So the ACL have a problem.
Dr. Lelli, if I can ask you about the same thing. As you said, the ACL arises from the tibial plateau, and it's the only structure which is holding the knee when you give a downward force, and probably that could be a scientific reason. But sometimes you can get those anterior capsular lesions on the anterior medial aspect and anterolateral aspect. So will this test will be different when you have associated ALL or associated anteromedial capsular lesion?
No.
When you are seeing a patient, do you have a different outcome with this, or you will get similar outcome?
No, the difference is that if you have a lesion of also fascial, because for me, the problem is not anterolateral ligament, it's a problem of fascia lata. If you have a lesion of fascia lata, the difference is that the jerk pivot shift is very explosive. In fact, if you have an explosive pivot shift, what I suggested to do only also in ACL reconstruction and an extra-articular reconstruction.
You must have done some studies at your center proving the specificity and the sensitivity of your test for the ACL injury. Is there any studies to prove the specificity and sensitivity of your test for the ACL ligament injury in your studies at your institute?
No. Freddy Fu did, I think, last year a study, and he says that my test have 92% of specificity and 95% of sensitivity.
So it's a very highly sensitive and specific test for ACL injury.
Yes, but remember, Roshan, we are speaking about acute lesion.
Yes.
Because for chronic lesion is different.
So chronic lesion, does this test is same or is different?
It's okay, but also Lachman test is okay, very easy to do. Okay. Because if a patient arrive after a travel, long travel, or with a lesion after 2 hours, he's afraid, he's contracted. He has a contraction of the capsule of the hamstring, and there is hematoma. It is impossible to do other tests. If you try to flex the knee, sometimes the patient has pain.
If you want to give anesthesia to the patient, you can demonstrate this test?
In anesthesia?
Yeah.
What?
Yeah, suppose say you give a regional block, regional femoral block, and you try to do this test.
Yes.
Is it possible? Is it possible, or is it?
Yes, yes, also in anesthesia. In fact, when the patient is in anesthesia, before to do an arthroscopy, what I suggest is to do always Lachman, jerk, pivot, lever test, always, to repeat also in anesthesia. But in anesthesia, the problem that sometimes the patient don't see, or he say, but the leg is with the spinal anesthesia doesn't work. But what I suggest to also to repeat this test is also after spinal anesthesia before to do a scope. And
yeah, Dr. Abhinav.
And another thing, if you see that MRI is negative, and my lever test is partial positive, you do a scope, and sometimes the scope is negative. You see the ACL normal. But if you cut the synovia, because, and you wanted to see the two bundle, you see an hematoma intrasynovial. And this, for me, it means that the patient need not a reconstruction, but to suture the ligament to the femur, or to use an artificial reinforce of ACL, not a reconstruction, but to suture the ligament or to reinforce.
Okay. So,
Okay,
any
Dr.
question?
Abhinav, last question.
Yes.
Yes, sir. Is there a landmark for positioning of the proximal lever in the region of the calf? Are there some physical guidelines as to exactly where to keep the lever for
Yes,
performing the test?
This is one fantastic question. The hand needed to be exactly below the tibial tuberosity. Exactly. And what I suggest, to do my test contemporary with the two leg flex in the same position. You can use a pillow or what you want, like a KT1000, to use to put the two legs in the same position, because one leg, another leg, perhaps the position of the hand is different. So the two legs in the same position.
And the second question was where to press it. At what level of the femur you want the pressure to be given? The mid thigh level, the lower third level?
Lower.
Lower. So very close to the knee joint?
Yes. But not with a big force. No, you can push. In fact, also a lady can do this test.
You don't require a lot of pressure.
And what I suggest, if you do an ACL reconstruction, you do the reconstruction, you fix the femur, okay? Before to fix the tibia, you can try my test, the lever test, in operating room.
We will do that.
And after you fix,
out of it. Yeah.
Okay,
Yes, Dr. Lelli, yes.
Can we go to the next talk, please, Dr. Lelli?
Yeah,
yes.
We can jump onto the next talk.
You see?
No, you need to share the screen.
Okay.
Dr. Lelli looks like no George Bush. The George Bush Jr.
Dr. Lelli, there is a compliment for you. You look like a George Bush, American president.
You see my?
Yeah, we can see it.
You see?
Yes, yes. Just make it full screen. Yeah.
The second lecture is about anatomic reconstruction, but also the method of fixation, because also the fixation is very important. This is a patient. I want a new ACL. So we need to restore two functional bundles with the same insertion, size, position, and orientation. Very important. Traditional, non-anatomic single bundle reconstruction does not adequately restore native biomechanic property of the knee. Very important is the diagnosis. We have saw before. The portal, tibial tunnel, the notch, femoral tunnel, fixation, diagnosis is very important. Also the portal, you see three different portals. Anteromedial portal in three different positions. And this is very, very important, the position. So what I suggest before to do a portal with a needle to see if this portal is okay for your reconstruction. Second, the selection of the graft. Here we have hamstring. We consider multiply strand, small learning curve, versatile for single, double bundle augmentation. But in many patients, the graft diameter is not okay, fixation strength is different, and multiply strand may lead to different tension. The quadriceps, length of the tendon most highly correlated to the patient. Less risk of quadriceps tendon, sorry. Less risk of injury of intracaphenous nerve. But sometimes we have a rectus femoral retraction with two proximal harvests. Initial rehabilitation, bit difficult, and sometimes we have a fluid extravasation during arthroscopy. Patellar tendon, very easy for bone integration. Rapid, reproducible bone-bone healing. We can have a more aggressive rehabilitation. But difficulty with kneeling, quadricep weakness, sometimes patellar anterior knee pain, sometimes patellar fracture or the rupture of the patellar tendon. So the perfect graft, stronger graft, needed to be a sufficient length and diameter, low donor side morbidity. We needed to incorporate fully and quickly within bone tunnel and able to reproduce the biomechanical characteristic of the ACL. So in this moment, the ideal graft doesn't really exist. What I suggest is a patient, is a basketball player, I use always hamstring tendon. Is a patient is a football player, I use patellar tendon. If I decide to use hamstring, but the diameter of the graft is less than 8 millimeters, what I suggest is to triple the bundle because 7 millimeters is very, very little. So the surgical technique also is very important. The insertion of ACL is not in the center, but you can see in this video, the ACL begin anteriorly under the transverse ligament between the anterior horn of the lateral meniscus and the medial meniscus. So good vision is vital during surgery. If the graft is too anterior, we have an impingement, you can see with the femur. So the exactly position of the graft is anterior, but not too anterior, and very near to the medial collateral ligament. So the tibial tunnel, you can see the tibial tunnel is anterior, but not too very anterior, but far from PCL, very far from PCL. Very important is also the tibial slope, because the tibial slope changes the inclination and the length of the tibial tunnel. You can see the difference. So an X-ray before beginning the surgery is very important because we needed to change the angle of the hymer. So the exactly position is very, very medial, near the medial collateral ligament. And remember that you needed to remain medial, not in the center. Because when you do surgery and when you do the tibial tunnel, the knee is flexed 90 degrees. And with the knee flexing 90 degrees, tibia is intra-rotated. So we need to be little medial. So when we go in extension, the tibial tunnel go against the lateral compartment. If it's possible, you need to leave the native ACL for 90% medical, legal problem, and also for a problem of proprioception. This is possible mistake. If the tunnel is too anterior, we have an excessive tension in flexion or impingement in the notch in extension. If the tunnel is too posterior, we have an excessive tension in extension or impingement against the PCL. We have a tunnel to medial, we have an impingement against the medial condyle, and these two lateral impingement against the lateral condyle. We can use a transtibial technique with articular arthrodesis or anteromedial. The advantage of the medial portal, femoral and tibial tunnel are placed independently of each other. Femoral tunnel is placed more anatomical on its native insertion site. And I wanted to see this because I know in India, but in Italy, 80% of my colleagues still now, 80% use transtibial technique. Tunnel placement is independent of graft type, fixation device, and tunnel guide. So, very important is to explain the difference between the femoral tunnel. You see, this is my experience. With transtibial approach, the femoral tunnel is very long, 48 millimeter, and the aperture of the femoral tunnel in the notch with transtibia is the average is 16 millimeter, with anteromedial tunnel is 11 millimeter. This is with transtibial tunnel and anteromedial tunnel. We can see the difference. With the transtibial tunnel, the reconstruction is not anatomic. So, very important is a footprint. Okay, posterior, but you can change the orientation of the femoral tunnel. You can see. So with the offset guide in external, internal, rotation, abduction, adduction, we can have various oblique tunnel, maybe drilled. And this is very important. The same footprint, but different orientation. In this fantastic book, the anterior cruciate ligament, about James Brown, Freddie Fu, Gobby, Owen Johnson, you can see that tibial tunnel must be parallel to the tibial plateau, parallel. And we needed to reconstruct an angle of 25 millimeter between the footprint of the ACL and the long axis of the femur. You can see in this slide, the point of exit of the femoral tunnel in the tibia is very near the lateral condyle. You see the difference and the angle of 26 millimeter. So for me, the point of exit of the femoral tunnel needed to be posterior to the lateral condyle. You see, and parallel to the tibial plateau. So, femoral tunnel, where? The footprint, the orientation, parallel to the tibial plateau. To drill, pay attention to the lateral posterior meniscus, or of the meniscus. And the length, remember that the femoral tunnel with this technique is very, very short. You see 30 millimeter, maximum 30 millimeter. Femoral tunnel, if the femoral tunnel is too anterior, we have an excessive tension in flexion or stiffening in extension. If the femoral tunnel is too posterior, the contrary, we have excessive tension in extension or laxity in flexion. Too vertical, we have a rotational instability with transtibial technique. But very important is also the fixation. So tibial tunnel, the graft, tibial tunnel, the notch where the femoral tunnel begins, and femoral tunnel fixation. A good fixation must cause a bone integration near the joint, not far from the joint. secure enough to resist slippage, direct contact with a new ligament, and remember, in addition, tunnel length and the percentage of the tunnel filled by the graft affect the time of healing. Remember this. So material very important for stability and must help the graft healing. The placement, very important, near the joint and not affecting the graft. And the fixation must be very strong, stiff. The screw, what I suggest not to use, because it's difficult to remove. The femur, in case of revision, is difficult. So, and with resorbable, sometimes synovitis. So, no fixation in the femoral tunnel with a screw. Cortical fixation, okay, strong, stiffness, good stability, very good for cause body integration. This is one of my medium with adjustable fixation. Okay, tunnel is a combo drill. You can see the graft with the scope is a femoral tunnel. Okay, the slippage, you can see here. And the graft. And remember that one major advantage of adjustable loop device is their adaptability to the unique anatomic of each patient. But we have a lot of paper that adjustable loop ACL suspension device demonstrate less reliability in terms of reproducibility and irreversible displacement. You can see the endo button fix, rigid loop fix, but with adjustable. We can see the irreversible displacement is different. And in this paper, you can see the rigid loop shows the lowest displacement between 1.7 millimeter and 2.8 millimeter. All the other device tests show displacement more than 2.8 millimeter. And very important is also to maximize graft into the tunnel. A lot of papers say that we need to leave maximum 4 millimeter between the graft and the cortical. Very important. This is the strength of the loop construct. You can see the difference between a fixed cortical fixation and adjustable cortical fixation. With fixed, the strength is more. And also the elongation of the loop with the fixed is less than with the adjustable. But the problem with cortical fixation, then in 25% of the patient, the fixation is not in contact with the cortex. This is very important. Secondary, the fixation is not in contact with the new ligament. And if you use hamstring tendon, the fixation is not near the joint line, but is far from the joint line. So if you have a stilo, a pen, it's very easy to broke if the hands are far from the joint line, not near the joint line. It's impossible to broke. And if you need to reconstruct a lateral compartment and you have a fixation like an endo button, it's impossible to reconstruct a lateral compartment. So what I have studied some years ago is this new fixation. The name is crosspin, not from lateral to medial, but from medial to lateral. You see this video? I put the two pin from medial to lateral, different orientation. I can check the exact position of the 2 pin with the video. I can use 2 pin, 3 pin, or different orientation. 2 pin from medial side and 1 pin from lateral side. So I can have a strong fixation, but overall, what we can see here, very near the joint line. Because remember that a decreased working length between the femoral and tibial fixation device may increase the stiffness and decrease graft tunnel motion. Because if the length of the tunnel is 30 millimeter, and if you use patellar tendon, no problem, because you have bone integration. But if you use hamstring tendon, you need minimum 25, 26 millimeter of bone integration, because hamstrings are viscoelastic, so they lose in tension and they need a stronger fixation. Also, the tibial fixation is very important. All the interference screws of the market are very similar. Similar nose geometry, similar trend pitch, that is the distance between trees. And the increased pitch, this is a new screw. We have an increased pitch, are able to, this space is twice that of the traditional interference screw, and reduce soft tissue graft twisting because of low insertion torque. And we have an improved pull-out resistance to the interdigitation of the graft and the screw trees. Very easy and very fast. You can see the left, the older screw, and the right, the new screw. Very fast. And overall, bone integration is more. So in conclusion, the ACL fixation method chosen should be considered both in the femur and both in the tibia. The immediate graft fixation strength and stiffness according to the graft which I have used, the surgeon comfort, and also the rehabilitation program, and the long-term clinical outcome. So, in conclusion, we need to identify and treat all pathology. We need to utilize strong grafter. Very important is a surgical technique, good fixation, both in the femur, both in the tibia. So, individualize the technique. Each patient needs this technique, not the same technique for every patient. A football player is different from a basketball player. A young patient, 14, 15 years old, is different from a patient of 50, 40 years old. A lady is different from a man. So we need to individualize the technique. Thank you very much.
Thank you, Dr. Alessandro. That was a wonderful talk. I think we can have few questions before we move on to his last talk. Anybody has a question to Dr. Lelli?
Dr. Alessandro?
Yeah?
Yes, Dr. Anta, yes.
Said in footballers, you use bone patella, bone tendon, right?
Yes.
And in basketball, you use
Hamstring.
I thought footballers have to have very strong extensor mechanism to kick the ball, to sort of curve the ball, you know,
yes.
compared to the basketball players who don't. Who don't.
In my experience, and also in United States experience, to use patellar tendon in basketball player we are afraid about patellar tendinitis. And so we prefer to use hamstring, or in some patients also allograft. Not hamstring, but anterior tibialis or posterior tibialis. In football players that running, I prefer to use patellar tendon.
Do your football
But
players,
Nicholas, remember that very important is also the physiotherapy. I don't believe that if you use patellar tendon, the patient can play again in 3 months. The rehabilitation need always 9-10 months, always.
in my practice, I find when I use mostly patella tendon, the quadriceps wasting which is there takes a long time to come up.
Yes.
And I can never have the girth of quadriceps as good as the normal one. How do you do this? Is there any tips and tricks to get back the quadriceps as good as the normal one?
No, I think that very important for me is an aggressive physiotherapy the first month, passive and active, with electrotherapy also, because you told a very important thing, that also if you use a patellar tendon, quadriceps suffer. So an aggressive physiotherapy the first month.
Dr. Lelli,
But, in my experience, if you use hamstring in football, a professional football player, in my experience, I had 20% of revision.
20%,
Revision.
Oh, I see. And in bone patella, never?
No, also in patella. But I think that if you patellar tendon, I think very important is a surgery, fixation, and not an aggressive rehabilitation to come to play again in 3 months or in 4 months.
I know the women's team in Italy is very good in soccer. Do you also do the quadriceps for the women also, or hamstrings?
No, football player also in the lady, I use patellar tendon.
Okay.
If the patient is want also an aesthetic problem, I use allograft.
Okay. Thank you.
Okay. Dr. Lelli, what is your preference of fixation on femur as well as on tibia?
Sorry for the question.
What is your preference of fixation on femoral side as well as on tibial side?
Allora, in tibia, I use always a screw, reservoir screw. In femur, I use cross-pin fixation. Only in some patient, in case of revision, I use cortical fixation. Because if I use hamstring, because if you use patellar tendon, no problem. Philippe Neyret in France, in Lyon, use press fit fixation with patellar tendon. So I think patellar tendon, the fixation is between bone. So no problem. But if you use hamstring tendon, I think that the fixation must be very near the joint line. Because if you have a pen, it's very easy to break if the hands are far from the joint line. It's impossible to break a pen like this. So if you use hamstring tendons that are viscoelastic, in my experience, I prefer to use cross pin very near the joint line.
This cross pins are biodegradable cross pins or metallic?
Yes, biodegradable.
So they are hydroxyapatite or PLLA?
PLLA.
Yeah, Dr. Lelli.
I don't know in India, but in Italy, the price, because very important is also the price, is exactly the same of endobaton.
We used to use this when we were using the transtibial techniques, actually.
We have used this from
yes,
my
but with transtibia, the old cross-pin rigid fix, you needed to fix from lateral to medial. But with anteromedial portant, you needed, we have changes the fixation from medial to lateral.
Okay.
Yeah, Dr. Lelli.
Yes.
Yeah. In what percentage of your cases you do transtibial technique presently, or all transporter?
Transtibial is some case of revision, but I don't like transtibial technique because the ligament is too vertical, and so it's not isometric. In Rizzoli Institute, still now use a transtibial technique but I don't like. If you use transtibial technique, you need to do always an extra-articular tenodesis. And for me, next article tenodesis is not always, it's only if you have an explosive pivot shift or MRI show a lesion of anterolateral ligament or fascia lata.
Yeah, even in athlete also, you don't prefer to go for this ALL or LET primarily, unless otherwise you get an explosive pivot.
Yeah.
Okay.
I don't understand the question.
Yeah, in elite athletes, you do primarily, you add LET or ALL in all your ACL reconstructions, or when you get an explosive pivot intraoperatively or under anesthesia in those patients.
Yes, only if there an explosive pivot shift, I use always an extra-articular tenodesis like Andrews.
Okay.
Or like Lemaire is the same. But remember that if you use, for example, Andrews technique, the fixation of fascia lata is very near the lateral condyle. Is posterior, proximal posterior the lateral condyle. And if you use endobaton, cortical fixation, in this position we have endobaton. So you need to remain more proximal with the Andrews technique, and this is not anatomic. So what I suggest, if you need to reconstruct only the ACL, okay, cortical fixation, cross-pin fixation, what you want. But if you think to do also an extra-articular tenodesis, you need to use a cross-pin fixation, an intra-articular fixation.
Okay, any other question? Yes.
Dr. Lelli?
Yes, Rajkumar.
I understand in your elite athlete, you have different choices of the graft, like the bone patella bone, as you're discussing with Dr. Antao, and hamstring for other group of athletes. Now we understand also that there will be failures in these group of patients. What would be the cause for your failures in these elite athletes that you choose, and when is the first time they will come back to you with their failures from return to sport?
If I have understand the question, is the difference between hamstring and patellar tendon?
No, you use for some people hamstrings, you use for some people bone patella bone tendon, correct?
Okay.
Okay.
Yes.
So now in those group of individuals, you do see failures of your procedure. All your procedures are not 100%. Is that correct?
Yes.
Okay. So what would be the cause of those failures in those percentage of patients that you see? Number one. Number two, when is the earliest that you have seen that your elite athletes will come back to you with failure in their reconstructions?
I don't understand the question, but the problem is I use hamstring tendon or patellar tendon. It depends about the patient, the age, the lady, man, it depends. Sometimes I use also allograft, and the rehabilitation is the same. Today, after the surgery, they begin immediately physiotherapy, because I want that after 1 month, the patient needed to be able to walk without crutch. But to come back to play professional football player, basketball player, 9 months. No 6 months, 9 months. Because bone integration is very important.
When you say 9 months,
yes.
Dr. Lelli, when you say 9 months, what are the clinical tests you say that this gentleman has to clear before he goes in for 9 months to return to sport? What clinical tests you want him to clear before he goes to sport?
Yes, I understand. We use a test that UEFA want now for the professional basket the name is Green Room. Is a test where we can see the force, the stress, the stamps from the hip to the ankle. Wanted to study all the patient, jump, running, and in comparison with the other leg. But I think that there is no one test that we can see, okay, if this test is negative, you can play again. So I think that the very important is a collaboration between surgeon, physiotherapist, physiatrist, and trainer. And also the patient, what the patient say. I am able, I feel well, I don't feel well. Very important is to study also the hip of the patient, because in my experience, I have seen a lot of problem of the iliopsoas muscle. So if the patient have a contraction of the basin, pay attention. So to visit a patient at the moment accident, 10 minutes. But to visit a patient the day before to play again, 3 hours. And I think that an MRI also perhaps is a good option to see the integration.
Dr. Lelli, I have a question related to again the clinical examination and the decision making. So what degree of pivot shift you decide and how you decide the degree of pivot shift? Because I think that is a very important critical question where we need to add the extra articular tenodesis or lateral plasty. So in those situations, how do you decide your decision making on the degree of pivot shift? Is there any criteria which you follow, or you follow it randomly as an examination?
I think that important is also the experience. But I think that in acute lesion, if during the scope I can see an hematoma in the lateral compartment, I prefer always to do an extra-articular tenodesis. In chronic lesion, only if you have an explosive pivot shift or a Lachman test more than 10 millimeter. And also, if what I suggest is to do, but this is chronic lesion, in anterior drawer test with a foot in intra-rotation. If an explosive anterior drawer test, always an extra-articular tenodesis.
Dr. Alexandro, can I ask another question?
Yes, please.
You operate all these elite players in the acute phase, or you wait for some time?
I thank you very much for this question. I prefer to delay it, always.
But your friend.
I want that the patient arrive in my consulting room, he needed to do immediately physiotherapy, and when no swelling, no hematoma, full extension, full flexion, no pain, surgery. If I can see with an MRI that we have a multi-ligament injury, on the contrary, I prefer to reconstruct immediately.
That means you don't believe in remnant reconstruction?
Yes.
So if you do the remnant...
Only in acute lesion.
Yes.
Yes. But in 48 hours, 72 hours, 3 days, no more.
I see.
But if you are speaking about ACL, if the ACL, the lesion is the femur, I try to reconstruct, to suture. But if the lesion is in the middle on the tibial plateau, no, I don't believe in the reconstruction, in the suture. Only if the lesion is proximal.
You see, when Zlatan Ibrahimovic had the ACL tear,
yes,
he went to your friend Freddie Fu and he got him operated immediately, and he was back on the field in 3 months' time. What is your impression about it? He had an ACL tear.
Yes, but you have an ACL test, but now if you have seen, Ibrahim have a lot of problem about the muscle and he have a lot of pain of the knee. He play, but with an injection because he have pain.
He plays for Inter Milan, right?
Yes, but he play only 20 minutes, not 90 minutes.
But Dr. Atta and Dr. Lelli both, I just wanted to ask you, does every ACL tear needs a reconstruction?
No.
Dr.
For me,
Atta,
no.
Yeah.
does every ACL needs a reconstruction?
No.
Oh, I will tell you one story of mine. I had seen one patient with ACL tear, and I fixed his operation, say after 3 months. And when he came after 3 months, it was already 6-7 months old. I said, I have not seen you for 7 months. Please don't get admitted. I have to examine you, and then I will operate you. But before that, you do an MRI. And to my surprise, his ACL was healed. I was saved.
Or rather, he was saved.
I agree with Nicholas. No, I agree with Nicholas. For this reason, I prefer to delay the reconstruction about 1, 2, 3 months, because sometimes if the patient is not a professional football player or basketball player, is like me or a normal people. If you have a synovialization of ACL with a PCL, patient have no problem.
Okay.
So in 20% of in my patient, 20%, 20 no, but 15% of my patient don't need reconstruction.
Yeah, Dr. Lelli. Yeah, what percentage of your patients, athletes, they return to pre-injury performance level? And if at all some of them, they don't return to pre-injury performance level, what do you think the causes may be? Where we are lacking?
80% of the patient return to the same level, but not after 9 months, but after 2 years, not 9 months. And I think very important is also if the patient had during surgery or during trauma a lesion of the meniscus. This is very important. So I think that the posterior or the medial meniscus and the lateral meniscus are very, very important. So what I suggest to suture always the posterior horn, not to cut away, because it creates instability. And also sometimes the patient is afraid to come back, because we have seen a lot of patients in Italy with a revision in 1 year or 2 years. So afraid the patient, and sometimes a bad surgery. So our mistake, because we have seen only the ACL and not, for example, a bone bruise or a lesion of cartilage of the meniscus.
Okay.
And if the patient has pain, don't come back to the same level.
Okay. Any other question? Yeah. I think before we jump on his last lecture.
One last question.
Last question.
Yeah. Dr. Alessandro, you said you don't have to operate when ACL normally falls on the PCL and joins the PCL. Those patients you don't operate, right? Am I right? Have I heard it right?
Yes, but it depends about what the patient say, because if the patient say, okay, I don't feel well, I have the sensation giving way, I suggest surgery. If the patient say, I feel well, no problem, I can jump, I can running, I don't suggest surgery.
What happened to the Lelli's test in this situation? Is it positive or negative?
Negative.
Oh, that's interesting.
Yes.
Despite of being torn from the femur, despite of not being in the right place,
yes,
PCL.
But
now you must give me another scientific explanation.
I try in 3 patients was positive, and in 5 patients was negative. So 3, 5, It depends, but I don't know why.
Very interesting, very interesting.
Yes.
Yeah, we'll jump on to the next interesting talk by Dr. Lelli on PCL. Dr. Lelli, can you share your screen?
Yes. You see?
Yeah, we can see. Yes. So, okay.
Okay. This is the last lecture about PCL reconstruction, my technique. Remember that the PCL, the insertion of PCL is totally different from ACL, is more longer, more vertical, and is more bigger than ACL insertion. So very important is the diagnosis, the patient selection, the degree of laxity, the planning pre-op. We need to identify and treat all pathology, primary repair versus reconstruction. Important is a surgical technique, fixation, and physiotherapy. Do not only trust on the MRI, because what I suggest, if you have a lesion of PCL, to do also an ultrasound, echography, arteriography, and also a CT scan, not only an MRI. For instance, an isolated lesion of PCL, we have only a translation of 5 millimeters, generally allow normal sport function without the need for operative intervention. On the contrary, an isolated ACL tear with 5 millimeters of associated anterior tibia translation frequently lead to instability, with sporting activity necessitating reconstruction. Very important is the examination, the trauma room of office, the MRI pre-op, and always to do an examination under anesthesia at the time of surgery. The energy of injury classification system category are sometimes arbitrary and does not alert the surgeon as to which structure needed to be repaired, because it's rare an isolated lesion of PCL. You can see in this video, PCL intact and a lesion of PCL. And you can see a more posterior drawer test if you have a lesion also of the posterolateral corner. So what I suggest is to do also always an MRI and a scope to see the periphery of the lesion. We can see the difference with this test with the PCL and posterolateral at 0 degree and 30 degree. Always to do an anterior drawer test in internal, neutral, external rotation. The principle of surgery, early repair, so is the difference between ACL reconstruction within 3 weeks of torn and the detached ligament, tendon, and capsule in acute injury. A combination of early repair and reconstruction has been shown to provide better results. This is my personal technique of ACL and PCL lesion. You can see before surgery, a big drawer test. The first step is the tibial tunnel. Very important is the orientation of the femoral tunnel and also the point of entry in the tibia and the point of exit in the tibia. Very important, because we need to avoid an acute angle between the tibial tunnel, acute, very straight acute angle between the tibial tunnel and the tibial plateau. Secondary is very important, pay attention also to the nerve, the artery that are in the posterior part. So what I suggest to do also an X-ray before to do the tibial tunnel, to be sure to be exactly in a good position. The first step is a tibial tunnel. You see, I use a 70-degree scope may be required to visualize the posterior view. You see, minimum 20 millimeter below the tibial plateau, below. And this step is very easy if you have a lesion of ACL. Very difficult if ACL is intact. I use this instrument. The name is Express, is for shoulder surgery. I don't like the posterior portal, lateral posterior portal or medial posterior portal, because I am afraid of the water of the nerve. I prefer to take time and to use a scope of 70 degrees to put the knee in full flexion, 120 degrees of full flexion, and to use this kind of express. You see, pay attention, the femoral tunnel, the tibial tunnel. Secondary step is a femoral tunnel for PCL, outside in, not in out, but out in. So first step, tibial tunnel for PCL. Russian know very well this technique. Femoral tunnel for PCL. Now femoral tunnel for ACL. I clean very well. You see the orientation of the femoral tunnel for ACL is very, very parallel to the tibial plateau. And the tibial tunnel for ACL. The fixation, I can use a screw, I can use endobutton, I can use cortical fixation. In my experience, for PCL reconstruction, I prefer to use cortical fixation outside in. Little incision, but I wanted to be sure that the ligament is directly in contact with the cortex. So, little incision near the medial condyle, and you can see the end, the two ligaments, the different orientation of ACL and of PCL. ACL is more horizontal, PCL is more vertical, different. And there is no mismatch between the two ligaments. And you can see the notch of the femur. There is no interference between the two ligaments. Before fixation, you see before surgery, and after surgery, good fixation. If you want, you can use also double bundle. Double bundle for ACL, both in the tibia, both in the femur. Double bundle for PCL, only in the femur, not in the tibia, because I think that 2, 4, 6, 7 tunnels are sufficient. 8 perhaps are too much. But very important is to see always the orientation of the tibial tunnel for PCL is not with an acute, very acute angle with the tibial plateau. You can see this is the two bundle of ACL. You see the anteromedial and posterolateral bundle for ACL. But my experience with double bundle, in my experience, is negative. What I suggested to use one bundle, big bundle, strong bundle, but one bundle, not two bundles. Multi-ligament reconstruction requires several tunnels. And for this, we have high risk of tunnel convergence. Because if you have a lesion of the PCL, in 99% we have a lesion of also ACL on posterolateral corner, anteromedial, medial collateral ligament. So pay attention to the divergence between the ligament, both in the femur, both in the tibia, but also because the tibial tunnel for PCL and the tibial tunnel for ACL different orientation, and also the point of entry must be very far, not very near. In conclusion, for PCL reconstruction, very important is the age of the patient, the pre-injury activity level, medical comorbidity, motivation for rehabilitation, because for PCL, rehabilitation is longer, and the expectation of the patient. So physiotherapy, we need to communicate, but also this for ACL, we need to communicate with the patient and therapist regarding goals and timeline for post-op physiotherapy. Because for ACL, what I suggested to begin immediately physiotherapy. For PCL, what I suggested to begin after 4 weeks. 4 weeks in full extension, and after we can begin rehabilitation. The risk, the benefit, the complication of PCL and also posterolateral corner repair should be discussed with the patient. And like for ACL, early return to activity may cause failure of repair. So, like Jack Houston said, good adjustment is based on experience, and experience is based on bad adjustment. So I think PCL reconstruction is totally different from ACL reconstruction. If I see an isolated lesion of PCL, I suggest always isolated, conservative treatment, always. If you have an associated lesion or multi-ligament injury, I suggest reconstruction or repair. It depends when happens the lesion. But PCL is different from ACL. Thank you, Roshan and Antal.
So I think the paper is open for discussion. Is there any question from any of the faculty regarding PCL?
Yeah, Dr. Lelli, how you ensure the neurovascular vascular safety without doing any posterior portal in your PCL reconstruction surgeries? Even if you are using 70-degree scope, but you are not doing any of the posterior portal. So how you are ensuring your vascular safety?
Okay, thank you very much for this question. In my experience, to do a portal, posterior portal or medial portal, because lateral portal there is also sciatic nerve is difficult, medial portal. For me, in my experience, personal experience, is more dangerous, more risk than to flex 120 degree, 130 degree the knee, so the nerve go far from the joint. It's not remain near the joint line. So I prefer to pay time. Remember that to do the tibial tunnel for me is 15 minutes. It's not very easy to do tibial tunnel, but I don't like to use port because I am afraid that also water go inside the tibia and to create a compartmental syndrome. But this is my experience. Is not what I suggest.
Yeah.
Because also to do a portal, posterior portal, is not very easy. You need a learning curve, very, very important.
I think we all have seen Dr. Lelli operating many times in Mumbai as well as in India. Everywhere he has demonstrated PCL. He has never done a posterior medial portal. And I was really surprised to see him not operating with posterior medial portal. But I think his technique of more flexion and using 70-degree scope is really good because I have seen it and witnessed it personally.
Roshan, I hope to show this also in next Congress in Mumbai next year.
Yes. So every time he comes, he's showing us and demonstrating some new techniques which are very, very important and in our clinical practice. So any other person has a question? Any panelist wants to ask? Yes, Rajkumar.
Dr. Lelli, you show in your tibial tunnel procedure on the image, your guide pin is exiting more superiorly than the 2 centimeters that you showed arthroscopically? Is it the same position that you want the guidement to exit from the tibia?
No, I show that I wanted to always, if it's possible, to do an X-ray, because I wanted to be sure that the point of exit needed to be 20 millimeter below the tibial plateau, not 25 or 30 millimeter, because it is impossible to use express. So I think that 20 millimeter. Remember that when you do a scope, you have the intercondylar spine in the notch, and so apparently it seems that the femoral tunnel is in good position. So you need to go with the scope posteriorly to see exactly the position.
So do you always use your image intensifier in the theater while you're doing PCL?
Now no, because the experience, I have already done a lot of PCL, so I don't use. But for the first 200 patients, I always did an X-ray.
Okay, your choice of graft for PCL is?
What?
Your choice of graft for PCL.
I don't understand.
Okay.
What is your
the
graft
of choice
choice
for PCL reconstruction? Hamstring, bone patella bone, CQT?
Hamstring. Because
Hamstring.
I think to use patellar bone is difficult for the two angles, in the femur and the tibia. And if the block is big, it's different to do this angle, also in the tibia. What I suggest is to use for the femoral tunnel outside in, because if you use in out, you have an acute angle also between the intraarticular part of the ligament and the femoral tunnel. If you use outside in, the angle is not acute.
Okay, now
and always cortical fixation.
Okay. This is one thing that I want to just ask you, because I assisted you for the surgery. Your preference of passing the graft is from tibia to the femur or femur to the tibia?
When
you do the PCL?
For PCL, okay. I use cortical fixation, so I prefer from the femur and after tibia. So if I use adjustable, on the contrary, tibia and the femur. But I try to use adjustable, I don't like, and so I prefer endobutton, normal endobutton, not adjustable.
So when you're using normal endobutton, you want to enter from the femur and then the tibia?
Yes, yes. Okay. It's more easy, no problem. And in the tibia, one screw, longer screw, because in the, this is very important. In the tibia, I don't believe in two fixation, one screw and one staple. I don't believe. I think very important is one fixation, not two, because one fixation works and one fixation doesn't work. On the contrary, and the screw must be shorter, because I want an integration between the ligament and the bone, not between the screw and the bone. On the contrary, for PCL, I prefer to use a longer screw, and if it's possible, also very near the posterior cortex of the tibia, for the problem of joint line.
Thank you. Thank you very much, Dr. Lelli. God bless you.
Okay. Any other question to Dr.
Done
Lelli about
enthusiasmo.
Sir, official language of this meeting is English, not the Italian, so we can't understand it. Although we started seeing Italian series on the Netflix, I think we are I think we are yet to understand many of the Italian words.
Yes.
Any other question to Dr. Lelli on PCL reconstruction?
The same question, Roshan, earlier regarding PCL fixation. Probably Vivek Pandey has presented that the screw goes right at the posterior aperture, but the screw is again conical over there. So how does it hold over there? What are the views of Professor Alessandro on that?
Dr. Lelli, do you push your tibial screw to get the fixation of the far cortex in PCL?
Yes.
So you put it
Posterior cortex.
Posterior cortex. You always
Yes,
take it.
and the knee in posterior Durower test. 90 degrees of flexion and posterior Durower test.
So
different from ACL, that the fixation is in full extension.
So how do you get that fixation? Because since the screws are conical,
yes,
the tip of the screw is very small, smaller than the base.
No, I use the same for the PCL and ACL, 1 millimeter more than the graft.
The bigger size graft.
Yes.
So you're making
or
10
hamstring. For patellar tendon, the same size of the tunnel.
So if you make a 9-side tunnel on the tibia, you'll put 10 size screw.
10, yes. 10, and if it's possible, 35 millimeter of length.
Okay.
So Dr. Lelli, if the screw is right at the posterior aperture, does it interfere in aperture healing over there by utilizing the space to heal over there?
I don't understand that option.
So Dr. Lelli, he's asking if your screw is, you're taking posterior cortex, is there any healing issues with posterior cortex screw as compared to the anterior cortex? Because your screw is occupying the space.
Not very near the cortex. I leave a minimum 20 millimeter.
Okay.
Because sure you need an integration between the graft and the tunnel.
Second thing which we noticed in your lecture is you spoke about the graft inside the tunnel. I think in one of your slides you spoke about at least minimum 20-25 millimeter of graft should be inside the tunnel for ACL reconstruction as well as PCL reconstruction. So do you still believe that the graft healing occurs inside tunnel or outside tunnel? Because the ISACOS consensus on the graft healing is something different. They speak about the healing at the mouth of the tunnel rather than inside the tunnel.
I think that very important is the integration. So I think that 25 millimeter, 25, 26 millimeter is a minimum for integration.
Okay.
So it depends about the length of the tunnel. If you use anteromedial portal, the length of the tunnel is very, very short. So if you use hamstring, also the hamstring are viscoelastic. So they lose in tension after 10, 15 minutes, they lose in tension. So I think that a good fixation near the joint line is better. But remember that if the tunnel is 30 millimeter and if you use anteromedial portal and the tunnel parallel to the tibial plateau, the tunnel is 30 millimeter. Also in the basketball player, if you use an endobutton minimum is 10 millimeter. 20 millimeter of integration for me is not sufficient.
Okay. I think
I think that is a philosophy, because I think it's very important is the orientation of the tunnel.
Yes,
also
Kalpesh.
But overall, the orientation.
I think he's using cross fixation pins in the as a fixation method. So at least he need a minimum
longer graft.
30 longer.
Because people who are using the cortical fixation, they are, I think, I attended last ISACOS and there is a consensus on graft healing inside tunnel versus outside tunnel. And they come out with a consensus group meeting that the graft usually heals at the mouth of the tunnel, not the inside the tunnel. Probably that could be one reason is the fixation device. As you're using more of intra-tunnel devices, we use extra tunnel device. Raghuveer. Okay. So I think we are done with the today's meeting. Yes, Dr. Anta, last question.
Dr. Alexander?
Yeah.
For ACL fixation, you say you want it away from the joint line.
Yes.
But when you talk about PCL, you want it near the joint line. Is there any scientific explanation for this?
No, for ACL, I prefer near the joint line because it's possible with cross pin. If you need to reconstruct the PCL for the moment, the cross pin for PCL doesn't exist for the moment, and so I can use. And also because the sponges of the bone of the medial condyle is different from the lateral condyle. It's more osteoporotic. So I prefer a cortical fixation. It's far from the joint line, but I prefer. And to use a screw, if you wanted to use a screw, if the tunnel is from outside in, it's impossible to use a screw because the orientation of the tunnel is different.
Insegnamento excelente. Grande.
Nicolas.
Entusiasmo.
Ciao, Nicolas.
Thank you. Merci.
Okay, I think I'll stop the YouTube. Let me thank Dr. Alessandro Lelli for a wonderful 2-hour session on the knee ligament injuries, the ACL, PCL. And we have been always using his test, Lelli's test. Probably will come up with some publication in short time on efficacy of Lelli's test during surgery. Intra-op, Dr. Lelli, I am testing it during surgery.
Yeah.
We discussed last time, 2018, when you are in Mumbai. We are using it before ACL final fixation and after final fixation. Probably our data will be released in another 6 months' time after COVID. And let me assure you, it is most important test which you can rely upon.
Roshan, I would say you do some femoral block and also do the test.
But that is, we are using intra-op. No? Our patient is already anesthetized.
Yeah.
So you mean to say pre-operatively under femoral block?
Yes. You talk to the anesthetist. Yeah. I am still confused why it is happening like this. Why when you hit on the thigh, the leg extends when the ACL is torn, and when the ACL is intact, it does not.
Even I was not convinced when I saw it in 2015, first time when Dr. Lelli was in India. I think his lecture was hall full and people were still interested in Dr. Lelli's test.
Yeah.
Because that was new that time. And something which is new is always difficult to digest, but it will take time. But I'm very sure it is working. Yes, but in our hand, it is working very well. We'll come up with our data. I'm very sure.
But Roshan, even ACL torn patients,
Dr.
some of the
Lelli,
patients.
Alexander the Great.
Yeah, so because we had a mixed report in preoperative testing, and I was confused whether it works in chronic patient, but we didn't use it in chronic patient evaluation. We use it as an intra-op measure, intra-op before fixation and after fixation. So before your tibial fixation, you just hold and check the Lelli's test. It is negative, foot is not coming up. The moment you do a tibial fixation, the foot is coming up. So that means there is something which needs to be explored there. So it is a very good thought which he has given to us last 2 years back, and we are working on it. So Dr. Lelli, you have always been a inspiration for many people in India. Thank you very much for your academic
Thank you, Roshan. Thank you, Anta. Thank you for all.
Thank you.
Bye-bye.
Ciao.
Ciao.